Good morning, everyone. This is Robin Shapiro. I'm the board chair of HealthAdvocateX, and you are attending Community Conversations, our now once monthly conversations that are focused still on COVID-19. As we have in the past, we're delighted to welcome Dr. Dale Reisner, who is Medical Director of GYN Quality and Safety at Swedish Health Services. And she's going to give us an update about what is happening with the pandemic and COVID and things to consider. As always, we'll keep everybody on mute until the Q&A. Feel free to put questions in the chat function, and we'll call on you if you would like to ask a question live, or I'll be moderating that. If you do not want your video to be part of the public broadcast, please turn your video off. And with that, I'd like to welcome Dale Reisner. Dale?
Hi, good morning, everybody. Can you hear me okay?
Yes.
Good. Okay, super. So I thought I'd start, we're going to talk a little bit about numbers, but I wanted to start with a question and some thoughts of really, why are we still discussing COVID? Lots of places are opening up, and so why is this still a topic for our community conversations? And I think there's a handful of things that are really important for us to be thinking about. First of all, we're continuing to see cases, and there are different pockets than what there were, a month ago, that are having higher swarms of numbers. But everywhere is continuing to see some cases. Part of this is from variants that have developed over time, and we will continue to see variants. So what we see now, what might be driving it now, is going to look different in a few months. We're all having closer contact. So pretty much everybody has taken some of our precaution away because we can't stand it anymore. And so we're seeing our friends and our families, and sometimes we're going out in public without masks, and many of us are vaccinated, but not all of us are vaccinated. So all of those things feed into why this is still a really pertinent conversation. And I'm hoping to make this fairly focused on those of you who are on the line who are advocates. What is this ongoing pandemic? Because we're not done with it. What does it mean as we continue and we open up and start seeing clients in person, and we may be going with them into medical venues, depending on where you are in the country, and try to make that be pertinent to the advocacy community, but also to anyone from the public and adjunct areas who are on this call. So if you have questions, for sure, put them in the chat. We'll address them later. And then I'll just go ahead with some summary of where we are with cases, and then kind of launch into a little bit different way of the conversation. So globally, there's over 187 million cases of COVID. These are documented cases, so there's more than that because in the early days, and even now, not everybody is going in and getting tested when they have symptoms, and we still have asymptomatic cases. So those are documented cases, and there's over 4 million deaths across the world. That's so many people that have lost their lives to COVID directly. In the US, we are better than those numbers. Obviously, we're less than the rest of the world. But we also, in the US, in the last week, saw a 16% increase of new cases than what had been seen the 7 days before. So and many of these are variants, but it just reminds you that we're not done. The Delta variant that you're hearing about is more contagious, and it's increasingly responsible for new cases, but it's not overwhelming. There's an Alpha variant that I think is the one that came from the UK or Europe originally, and that still is driving the majority of the cases across the country.
Did you say Alpha? Did you say Alpha?
Alpha,
Okay.
Alpha, yeah, because
Okay.
that was the first. So
Mhm.
they've been, alpha, beta, delta, gamma. I don't think we have epsilon yet, but maybe we do.
Mhm.
And they all have numbers. And many of the state public health and epidemiology groups are actually doing at least random testing of new cases to see where they're coming from. So all of these variants seem to be a little bit more infectious, not necessarily more severe, but more contagious and easier to pick up. And a lot of those cases are in the younger population that either have chosen not to get vaccinated or didn't get vaccinated yet, because we focused on the medically more at risk in the older population when we first started vaccinating. So in the US, our total number of cases is over 33 million. And we've had almost 605,000 deaths in the US from COVID. And again, directly from COVID. Those are probably underestimated. Again, not every person who dies that might have a medical condition also is being tested for COVID. And we know that a lot of losses, especially early last year, were not accounted for. We're now in the US doing pretty well with vaccination, but we're not up to the 70% goal that the current administration had hoped to be at by July. So if you look at least one vaccine dose for every age group in the population, we're around 55%. And about 48% are fully vaccinated. So that's not bad. I mean, if you look at India, where 3% of their population or less, depending on what you're looking at, we're not that bad. And I think I mentioned on a prior call that there are some countries that are aiming for at least one vaccination for more people and then catching up with a second later. And then if you look at a subgroup of those who are 18 years or older, so the population that's had a longer period of time to have access, we're at 67% in the US, which is really awesome for one dose, and 58% for fully vaccinated. So that trend is great. I think we still want to reassure people that the vaccine is much safer than the wild virus, and nothing's perfect. And so by
And when you
getting
say wild
vaccinated, when I
virus,
say nothing's
wild virus
the
meaning,
wild virus is the COVID, whatever variant happens to be in your neighborhood, that's
yeah.
the wild virus. Exactly. Yep. And just a reminder that the vaccine is not 100% going to prevent every single variant, although it's working quite well against severe disease. It's not perfect. When we first started seeing the variants and seeing it in fully vaccinated people, we did not see any deaths. And we can't say that now, but the rates are really low. And they have been pretty much in people with other comorbidities, which would be, either a higher risk by really high BMI, the more obese patients seem to be more susceptible, or other complications such as immune suppression from some reason, and also underlying chronic illnesses like significant hypertension, diabetes, those kinds of things.
And Dale, just to kind of put it into context, because we last month had a robust conversation about not vaccinating and that kind of thing, and people who are waiting because they want to see kind of how it all shakes out. But put it into context for us, if you can, I don't know if you have these data right off the top of your head, but the worldwide and or US total vaccination in terms of numbers in the millions or hundreds of millions, like how many hundreds of millions of people have been vaccinated, just to kind of put that into context.
Yeah, I don't have global numbers. I would have to look at the US population in terms of that breakdown of like who's 18 years and older and that kind of thing to give you those exact numbers. But and
not
I didn't,
even
yeah.
not exact, but we're in the hundreds of millions of people who have received these vaccines.
Correct.
So
Correct.
when you're talking about, you're going to talk a little bit about breakthrough infection rate, and the fact that the vaccines are not 100%, we would expect to see some of that, right?
Yes, we will. We will. And, I think it's really awesome that we're so close to 70% vaccination, 1 dose in those who are 18 and older, because really the bulk of the newer cases are coming from 20, 30, 40-year-olds. So people that really, weren't first in line for vaccination unless they had some other significant medical issue. And it speaks to more of them. However, it's really important to look at your own area in the country. Rural areas, way less vaccination rates, even though vaccine is available. They've had unused vaccine in many rural areas, and that's in every state in the nation. And in some populations, and I'm going to talk about that a little bit, some populations, we see lower vaccination rates, and there's a reason for that. And it's not, some of it's supply, but some of it is hesitancy. So if you look in your own state, you will see some states are very low overall vaccination rates, and others are not. Washington State, we're over 70% for at least 1 vaccine. So, we've had a very aggressive campaign for that, a lot of reach out into the community, and
we were
still
also
in Washington.
First, and we were also first to have.
We were first. we were the first identified to have a case. Yes. Yeah. But we know that COVID was in the country as early as last December in the US. Yeah. And so we don't know where else it was, if it was really first in Washington or not. But yes. So yes, we've had very aggressive public health work in our state, really committed to getting as much supply as we could and so on. So yes, we had we had some advantages, I think, compared to some places where there was like a hesitancy by the leadership. And that, of course, makes it much harder for anyone in medical care, for advocates, for, public health officials to do their best job if there's not leadership in the state to support that.
And we just got from Shar, thank you for looking up the data from USA
Total
Facts. Numbers. 183.2 million people have received at least 1 dose, and 158.2 million fully vaccinated in the US. And so you would imagine around the world that would mean multi-hundreds of millions of people who have had these vaccines.
Yeah. And again, there's some countries really good and some countries where they don't even have vaccine, right? Yeah. So a lot of work now happening, thankfully, in places like the Gates Foundation and things like that, to try to expedite getting vaccine to some of the countries, parts of Africa that really have had none. So and I mentioned in our country right now, the highest of the variants in terms of new cases, for about 44% of the new cases is the Alpha variant. And then the next most common 30% is the Delta variant. So if you're interested in those types of things. So I think that when we're talking, and we'll move off vaccination a little bit, but when we're talking about advocates and vaccine, there's a couple ways to look at this. And one is your own personal choice about getting vaccinated, and the other one is who you're advocating for, what their choice is, and how we can help the dilemma of, if you as an advocate are not a proponent of vaccination for your own self, can you be an effective proponent for your client who may be at much higher risk than you are personally to get ill? Because most of the clients have something going on with them, otherwise they wouldn't have a healthcare advocate. So I think that's, I don't have a solution for that, but I think it's a great question for us to be asking ourselves. And then from the other perspective, what if you're a vaccinated advocate, but your client is not interested in getting vaccinated? You've done your best to convince them that the vaccine is safe and that it will protect them, but they're not interested. Are you going to refuse to take care of them? Are you going to mask up when you're around them still? And so there's some personal choice here I think we all are going to make. One would be working with clients, and one would be when we're socializing with our families and going out in public, whether we're vaccinated or not vaccinated. So
Yeah,
an
and
example would be, yeah.
I was
Go
going
ahead.
to say, Beth had a really good, I don't know, Beth, if you want to jump in here, you had a really
Sure.
good story personally.
Yeah, I
on
have
the-
we have 94-year-old friends who they're spending their summer in Sun Valley, but they have a house in Walla Walla, and they went home to be with their family, and they've been vaccinated for a long time, and all their family was vaccinated, but someone there wasn't. And even though they were vaccinated, they got COVID. And they were shocked because, they had no idea where they thought it was their family. So I think you don't know when you're in a room full of people, even if people say they're vaccinated. So like what Dale said,
Yep.
we have to make personal choices about it. And luckily she is not real sick, but at 94, there's a lot
Doesn't
of
take
things that
much.
could go wrong.
Yeah.
Yeah, I'm
Yeah.
going to put a question in the chat that she asked me about brain fog, and if you can answer it.
Oh, great. Yeah. Put it in the chat. We'll get around to
We'll
it.
Cue it up. Thanks for sharing.
So yes, thanks, Beth. And that's super important. And what I was going to say is me personally. So I've been fully vaccinated since February, I guess. No, maybe January. But when I go into the store, the grocery store, where there's a lot of people that and many of them are not wearing masks now, I still wear a mask because I don't really want to get even a mild form of COVID, because we are seeing, lots of complications from COVID, even for those folks who are mildly affected. And I would never want to be responsible for infecting somebody else, by having an asymptomatic version of COVID where you don't know. So, when I'm outside, I'm more comfortable not masking. So I think you just need to ask yourself and your closest family members, what are we comfortable with, and work with that.
So can I just clarify something? So somebody who is vaccinated can pass on COVID. They can carry COVID and pass it along. Is that?
Yeah. Well, as far as we know, there's nothing we've seen so far that says if you have picked up COVID from one of these variants, then you have a mild case that you can't infect somebody else. You may be a little less infectious because you've already got circulating antibodies, but we don't know for sure that you can't pass it along to somebody else. And then obviously, if we are feeling more comfortable about going without masks, just be careful that we keep washing hands and keep a little bit of distance away from strangers if you can when you're in line or that kind of thing. We still have these, tapes on the floor in a lot of places, and I stay back 6 feet till
Yeah.
it's my turn. I just think, we've got other things coming up, and I was going to address that at some point, but I'll just pop it in now.
Yeah.
We did not really have a flu season last year. We will have a flu season this year because people are doing more stuff. And what we're starting to see is other illnesses, viral illnesses that we would typically see in the winter are showing up now. And there was an article looking at kids. So a lot of kids are like so happy to be able to get out and see their friends. And oh my gosh, they need it, right? They need it for the psychology, the emotional support, just to be able to run free and so on. And even with outdoor engagements, we're seeing kids getting sick from other kids. And sometimes it's not COVID. So there's a surge right now in our area in Washington State, and I wouldn't be surprised about other places in the country, of RSV, which is respiratory syncytial virus. It often affects really young kids, and it's really, it's something we've seen in like babies that are premature, why we have them stay, families keep them in the house away from others for a longer period of time.
And there is an RSV vaccine, I know. There's
yeah, but it's not widely available for like the general community. And so we're seeing not just babies, but we're seeing toddlers and young children picking up RSV. And mostly it's like a cold, but some kids can get super sick, and there are deaths occasionally from it. So it's interesting because, I know a family that I suspect that's what they have. They were in several outdoor swimming, running around, playground type stuff at 4th of July. The kids in the family got sick, the adults are not. And they've got COVID tests pending, but I'm not sure that they got tested for that. So just keep in mind that whatever we do personally or our clients do, as we let down our guard that we've had for the last year, we're going to start seeing some things. Most of us have been pretty healthy in the infectious disease part of the world, as we've been more confined. And as we maybe are not as meticulous about hand washing or that distancing or, dining indoors, I think we're going to start seeing some of the GI diseases that we typically get in restaurants, salmonella, listeria, some of those things as well.
And what I've noticed is
and it's
that
be-
there's and I'd be curious to hear people on the call. People are unsure about the handshaking, and I've heard that doctors believe that handshaking should just like go away completely and never come back. But I think about that when I was at a party indoors because it was 105 degrees here 2 weeks ago or so. Some people might have heard about that if you live outside of Seattle. And I was in a smaller house indoors with 40 people, and 3 people grabbed my hand to shake my hand. And I was startled and worried, and immediately made a beeline to the sink to wash my hands. But so it would be interesting to see how culturally we adapt to that.
Right. Yeah. Keep your Purell handy when you're out in public. Yeah.
Yeah, I was telling these guys yesterday why, if you ride public transportation, which a lot of us haven't, but I was on 2 ferries this past weekend, and I would say 20 to 30% of people were wearing masks, and it's a mandate, on public transportation. So you just have to be really conscientious for your own self and family and clients.
Hey Dale, we have a question here about if there's been this is from Melissa Collier, any headway to the 12 and under vaccine. Do you have any news about that?
Yeah, I didn't pull data on that, but yes, there are, I know Pfizer's gone to the FDA for full approval. I think Moderna is planning on doing it as well. So I think the access is going to be, at least from the like 2 and above, is going to be pretty liberally available. I do know that there are lots of states looking at encouraging versus mandating vaccination for kids returning to schools. And I think that mandating is challenging. Mandating is challenging when we come to even measles, mumps, rubella, right? So, but you may see that, and certainly you may see in certain private companies that they may mandate vaccination for all employees, and they're allowed to do that. When you get to larger, more public businesses, I think they'll strongly encourage but not mandate. So again, I don't know if they will require proof of vaccination or mask wearing, and that would be reasonable for large companies that have a lot of public exposure. But we haven't seen enough from some of these bigger companies. And right now for healthcare, it's quite variable across the country. In the facilities that I work in, Swedish, in the Seattle area, we mandate that when we're in public areas, that even if we've been fully vaccinated, that we as healthcare workers are wearing masks, the regular masks, not necessarily N95s or anything. But I do know that there are other parts of the country, even in the thick of the pandemic, where providers were not necessarily wearing masks. So yeah. Again, you really have to kind of look at your own area and balance out, how concerned you are about potential risk and protect yourself and or your client accordingly. So I did want to talk a little bit, and then before we open it, and we should have plenty of time, I think, for questions, but is one of the things that I think that's really pertinent for those of us who are advocates in healthcare is what has happened secondarily during the pandemic, and that is delay in care for routine follow-up visits for simple things like your annual visit for something, but also particularly in cancer screening. So there's a little bit of information, just even during the first 6 months of last year, there was about a 40% delay in United States adults in even accessing emergent or urgent care. Pretty impressive delays. So in the urgent emergent category, about 12% of the US population delayed seeking care. And when you look at rule out complications like heart attack, stroke, diabetics in poor control, which is a life-threatening situation if they go into ketoacidosis, big delays in people seeking care there. And so what that is called is excess. So excess, either death or morbidity, the complications from those conditions that may be known or newly diagnosed, is a thing that we are just kind of starting to grapple with. And I wanted to bring that up because as advocates, if your clients have neglected their routine screening, like do you need a pap smear for cervical cancer screening? Are you getting your breast mammogram for screening there? Colorectal screening, big hit. And colorectal cancer, of all of these, is the one that moves the fastest. So I'm going to give you some kind of frightening numbers that come out of the United Kingdom about what they think the impact will be. Yeah, and follow-up. So there are people with chronic conditions that haven't been going in for routine follow-up. And, I wear glasses, right? I haven't seen my ophthalmologist. Now, I could have gone and seen my ophthalmologist a couple months ago. I wasn't going anywhere, the dentist, anywhere, until I was vaccinated. And I did go to the dentist, but I'm now having to figure out what thing to do next, and because I'm behind on a lot of my follow-up.
And that is
I, as
definitely
a
an
physician
area
who's a
that,
healthcare,
yeah, that's definitely an area that
we all,
advocates
yeah,
can jump in and
you
help and
can help,
support.
you can
Mhm.
help and take care of yourself as well. Yeah. And then the thing I wanted to mention is this, not surprisingly, has affected the health inequality that we have amongst racial and ethnic groups. So we have seen really sharp declines in breast and cervical cancer screening amongst women. For breast cancer, decrease in 84% in Hispanic population for screening, and a decrease of 98%, like hardly any people getting breast cancer screening in the Alaska Native and American Indian population. So pretty dramatic drops in those compared to Caucasian. We still have drops in Caucasians accessing that screening modality as well. And then for cervical cancer, an 82% decrease in the Black population for women getting cervical cancer screening with pap smears. And 92% decrease in the Asian Pacific Islander population. So if you are working with anyone in those areas, then that just those simple routine screens are a good thing to remind folks about. And again, neither breast cancer nor cervical cancer moves very fast. So we're not way far behind if people can get in and get screening now, but it's just a good thing to remember that those screening tests really do detect things early enough to treat and prevent death. And I think that for these populations, there's, and for the emergency access stuff too, there was a fear of exposure from hospitals for COVID, am I going to go to the hospital and get it? And any of you who've heard me over the past year have said, the hospital might be one of the safer places that you can go, probably safer than the grocery store or, Walmart or those places. And then some of the states and some of the countries had greater degree of lockdowns. And so people were not going out because they felt like they should wait, on purpose. In the United Kingdom, which had several lockdowns, they didn't last long periods of time, but they had a whole country lockdown. And remember, the United Kingdom is about the size of some of our states and smaller, certainly smaller than California and Texas. So that, it's similar to a whole state locking down. They've estimated an increase in deaths due to delayed diagnosis. And if you look at the cancer type, it ranges from almost 5% to almost 17%, with the 5% being more for the breast and cervical cancer types of slower moving cancers, and close to 17% for colorectal cancer. Probably not a huge increase for lung cancers and things like that, and in part because that's a lot of people that are at risk are not getting screening in the first place. It's a newer type of screening.
And we don't have US numbers on excess deaths yet, or that's something that's being studied?
We don't have great. There are people doing modeling for that, what they think. And again, this is in part modeling, but based on the number of diagnosed cases that they have already, and what the anticipated pickup would have been with screening.
Mm-hmm. Yeah. Can we go ahead and pick up that question that Beth had? She has an older friend with COVID and talked about brain fog from COVID. Mm-hmm. So we're talking about the long COVID, long lasting effects.
Right.
Is there data around that, or how will we know what the long COVID stuff is going to look like?
It's going to take us a long time to figure it out. It really is. Because here's the deal. What we're seeing that probably isn't long COVID, but feels long, is there are several months, not uncommonly several months, for people to get over the effects that the COVID infection has had on their system.
Mhm.
And then there are people that are out like, 9 months, a year, that truly have long COVID. And so brain fog seems to be something that hangs on for several months, 2 to 3 months post infection,
Mhm.
and may not end up being anything that
Mhm.
stays with the person. So I think it's important for us to reassure people that it takes a really long time for our body to get over this infection. We're also seeing that with exercise intolerance and fatigue. So if you had pulmonary, if you had a really bad long-standing cough, shortness of breath, big time fatigue when you had COVID, those tend to last months. And the sense that you're not getting back to your normal activity may take a long time to recover, but still could recover. So I think we don't have a clear breakdown. It's obvious that if somebody's having, recurrent headaches, and we're now starting to see some mental health disorders in people that never had them. There have been some isolated reports of COVID, and within weeks, somebody having an overt psychotic event that
Wow.
never had any mental health disorder before.
Mhm.
And it goes back to what they're preliminary looking at with that type of neurologic impact
Mhm.
is antibodies that are showing up in the brain. So one of the things that I've been asked in the past, and it's just been my sort of clinical suggestion, is that what is being triggered for many of these people that really have long COVID, so it's been, a year or 9 months, is an autoimmune type of response. And it looks like that might in fact be what really is happening. And we can have those, with all viruses.
Yeah. Because viruses do sometimes translate into all kinds of disease, right? I mean, they're even
Right.
saying that, my dad died of glioblastoma brain cancer.
Mhm.
And they're saying that there's some evidence to show that that type of cancer is actually triggered by virus.
Yes.
So, which is interesting.
Yes.
But I wanted to ask you about, we, throw around long COVID as a term, but is
Mhm.
there a definition of long COVID? Like how long, or what
There's a whole,
criteria?
yeah, I don't have a great definition for when you get from what's unexpected. I would say 2 to 3 months would be your longest sort of expected period of time to recover. And, if you go beyond that period of time, I don't think anybody's really knows yet to say what's the extent of full recovery versus those who don't seem to recover. And I think that is, that will emerge probably in this next year as we have less active cases and a little bit longer time for follow-up.
Yeah.
But if you have protracted symptoms for months and months and months, then most practitioners are saying this fits into something that would be long COVID. But it's going to look different for different people. There are people that just have so much fatigue they can hardly function, but everything else is okay. And there's people with a lot of neurologic symptoms. So there may be behavioral health stuff. Really fascinating, this one case that brought to light the possibility of mental health disorders with the psychotic event that emerged 2 weeks after the initial disease. That individual was treated, and he's I think he's taken his story public. I don't have his name, but so I'm not sharing any personal HIPAA information. But and then he was treated and got better, and then had this huge relapse, and he had circulating virus. So it was fascinating. We don't know if he got another infection or what happened there, but definitely the body's response, and again, that's antibody, right? So is the body responding it can get calmed down and it can sort of have a reemergence. And that's really typical for much of the autoimmune diseases that we see that get triggered by viruses. Yeah.
So that would be a good topic. Probably everybody online knows that we are hosting a live and recorded virtual conference November 4th and 5th. And I won't do a plug for it. We're actually opening up tickets this week, actually. And we have a call for speakers right now. And it would be interesting from the people online to just take a peek at our call for speakers as we're, thinking about topics that we want to cover. The topic is health advocacy now, lessons from the pandemic. So we're trying to basically take a look at how health advocacy has or has not been impacted by COVID and the patients that advocates work with. So just a little plug there. But one of the things I also was really curious about, and now actually everybody who's online, now's a good time to throw your questions into the chat. If you have them, we have about 20 minutes left. I was really curious of the people who got vaccinated early. So healthcare workers and other people that had early access. What are we hearing about either their need to get a booster or their immunity? Do we have any data about that at this point?
I don't know that we have a lot of data. There are starting to be recommendations from experts in the area, that the Anthony Fauci's and people like that either are virologists or epidemiologists or public health officials, when boosters are available, and there will be boosters available, that even fully vaccinated people, and I don't know when the break in time is, so how many months after vaccination, they will say it would be wise to get the booster. A lot of this, because this is such a novel or new virus, we don't know, so we are kind of going based on what we've seen with other diseases. And the idea of boosters is it's good. So that would be like, are you going to get your flu shot? And, can you get them together? No. Initially, when we started doing vaccinations, they said wait 2 weeks between any type of other vaccination. Now they're not saying that because they've seen people vaccinated, within short proximity for COVID of another vaccine. And there's not been a problem with the body mounting an immune response. So as we get more of this immune response data, I think we'll have a better sense of antibodies wearing off, or how long you're protected. There's been some studies looking at least a year of circulating antibody, but we don't know how protective that would be.
Yeah. We have a question here from Judy Finn, and I don't know if you can answer this question, but it says, in general, how successful have assisted living and other congregate care facilities been in adopting effective protocols to protect residents from infection? And I know that, that was a huge thing to wrap our arms around, especially here in Washington State. And also I might point out that Tina Hall from Era Living also is online and might be able to assist in answering that question.
I'd love to hear from Tina with her comments first. Yeah.
Hi, ladies. So, as the rest of the world starts to unmask and gather and such, senior living facilities, we're a little bit behind. Our Safe Start plan is a few steps behind the rest of the state. So we're still masking, we're still limiting exposure, we're still social distancing, we're still doing all of those things that we've been doing for months. So we're continuing to be pretty cautious and following infectious disease protocols. But the good news is, since everyone's been vaccinated, we've seen practically 0 cases. We haven't seen any deaths. I mean, the vaccine has been completely, really effective in senior living communities. So they're probably the safest places a senior can live,
Yeah.
right? Because they are so well protected, and they still have access to all kinds of additional services to keep them out of places that perhaps they don't want to go, where there are a lot of people unmasked and gathering in large groups. So, I think it's going to be a while until we see a return to normal within our communities. We are still not doing activities that include people from outside of our communities. So, for example, instead of doing lectures where we invite the neighborhood, nope, we're still doing those via Zoom. It'll be a while before we actually allow people to come back into our communities. I'm guessing probably not until fourth quarter. We have started to have small gatherings of people outside in our gardens and our courtyard. So it's great that it's summertime, where this winter we would still be kind of just in a holding pattern. But, like I said, it'll be a while until we are back to normal, like the rest of the world. And that's okay. I mean, I think senior living communities would prefer to go cautiously and make sure that residents, and I'm not just speaking strictly for my communities, but I mean in general, very cautious and making sure that first and foremost we are protecting our residents' health and well-being.
Super helpful. And we had another couple questions come up related. So so Gazelle Tan asks about vaccination rates among staff. And I don't know if you can speak about that broadly. A
little bit.
Yeah, that would be great. Thank you.
It's been interesting because among residents, and this is true with most communities as I understand it, the resident acceptance rate with a vaccine is 99% or higher. So residents are clamoring to get it. They've got it. It started off a little slower with employees. I think that as an industry, we really only saw about 70% initially getting it of our residents. Of employees. That number is going up gradually because we're continuing to educate and encourage. We're now up to about 78%, but initially when we did this, we were only at about 70%. And it's mostly the younger population, some of the folks in dining services and housekeeping services. And there are a variety of reasons why employees have expressed hesitancy, religious, cultural. I mean, there are just a number of different reasons. But again, as that continuing education happens, those rates are going up. It's interesting because as an industry, we're not at a point where we can really mandate it, although it could go that direction. If other industries start to mandate that people get vaccinated, then I think we will as well. The other thing that I think is helping with our younger population of employees among assisted living communities is that a lot of them are still going to school part-time, college part-time, and a lot of colleges are mandating that they have to get the vaccine. So even if we're not doing it, if the educational institutions are, that's also going to up the rate of vaccinations among employees.
So interesting. This is very, very helpful. So I'm so glad, Tina, you were able to make the call today.
Thank you.
There's one more question related to this, which is, this comes from Dale H. I'd like to visit a friend who lives in assisted living. What should I do to be sure it is safe for me to visit? So
first of all, know that residents have very likely been vaccinated, but if you're concerned, you can ask the resident specifically that you're visiting if they've been vaccinated. And if you've been vaccinated, you've got that double layer of protection. However, what's going to happen is when you go in to visit, you're going to be screened. You're going to get a temperature check. You're going to have to fill out the whole screening, and you can only visit the resident in their apartment. So you can't be out in the public areas. You're not going to be able to go dine with them. So part of that is about protecting the residents, but it's also about protecting you so that if there is a case within the building, you are less likely to be exposed to it. Luckily, there haven't been, but we're, like I said, we're going cautiously.
Tina,
thanks, Tina.
Can your residents request a vaccinated caregiver or staff person?
I don't know the answer to that, Beth, but I will find out. That is a very good question.
I'm just curious. It's just, my sister's in a facility and her husband has requested only vaccinated staff, and sometimes there aren't that many. It's kind of interesting to me.
Well, that would be my curiosity too, is if there is a shortage within a community of vaccinated caregivers, what does that mean for residents? I will find the answer for you, Beth. I'll find out what, at least I can find out what we're doing.
What you're doing. Yeah. Thanks.
Yeah.
Yeah, and thank you, Sharman, sharing that she's on the board of an adult family nonprofit, and some caregivers are choosing not to vaccinate. So I would imagine that this hesitancy in assisted living, adult family homes is an ongoing issue. And actually, I mean, just finding qualified caregivers, there's just feels like there's a real dearth. I've heard many people that I know that are advocates or family members having a very difficult time finding qualified caregivers overall. It's just really, really tough.
Yeah. And, I think it also goes back to when we talk about the health equity disparities. Many employees that work in the assisted living and or full care types of facilities are quite a range of ethnic backgrounds. And if in their community there's distrust, which there is a lot of distrust in either medical care or in new things like a new virus vaccine, that may be impacting caregivers as well. So, you are a lot of your core family and your core community when it comes to new medications, new opportunities such as vaccinations. We may see some hesitation that way. There may be some private companies that are requiring their employees to be vaccinated, and smaller companies can do that in a way that larger organizations like ERI Living and some of the other bigger organizations can't do, as Tina was saying, at least not right off the bat. So I think that that will continue to be, and we'll just see how that plays out over time. The other thing just about employees is with the pandemic, with so many people not going into work, there are a lot of companies, food establishments, even healthcare companies that can't get enough employees back to work. And we're seeing huge numbers of shortages of supplies. And I suspect that's affecting the home care facilities as well. And there can be really common things like, syringes or, something really simple.
So, I mean, what I think the bottom line of this conversation, we did some prep yesterday, actually, as we always do, to kind of talk about what's happening of the moment. So I just want to take a minute to thank Dr. Reisner, thank you, Dale, and Beth Droppert and Kristen Tellini of Pinnacle Care, who's not here, but helped prep. So what we're really facing is we're not done with the pandemic. Even though it feels like, and we want to be done, we really want to be done, but the impact of the pandemic, really, we're going to be feeling for some time. And what I took as a hopeful sign, though, is what we've learned during the pandemic is that we individually can take more control than we might have otherwise thought in terms of continuing to choose to mask, hand wash, social distance, doing all the things that we did during the pandemic that maybe we want to shed because we want to see one another's face and stuff like that. But we do have the opportunity to actually take a bit more control for our own selves. We have that choice. I think we just lost Dale. We do have a few more minutes to answer your questions if you want to put them in the chat. And Dale, I don't know if you wanted to add to what I just said.
My video keeps going off, so maybe my iPad is sick of me.
Dale, do all Swedish employees have to be vaccinated now?
No.
Yeah. Okay.
Nope. Yep. And, they're masked and hand washing, and we still have strong recommendations about no eating in the public areas, things like that. And as Tina was saying, healthcare is going to be cautious about, more frustratingly cautious about number of visitors that they allow and things like that, for the very reasons that she said. They're having visitors go to apartments, or some places are scheduling visiting in a certain confined area. Those kinds of things are happening. But in hospitals, I think, depending on how strict they were in the first place, you're going to see continued limitations longer than we want for visitation.
So any other questions, any other kind of final thoughts before we wrap up for the day?
One of the things that Kristen brought up yesterday, just so that some of the advocates in our community can know, is that you can, even though the healthcare system is not allowing more than one visitor, if you have a patient with really serious needs and the family is totally burned out, you can get a special dispensation to be able to go and help out. So it's worth pursuing that, but you probably have to go above whoever you're, on the floor. You probably have to go to administration and work on that. So, and Dale, you can comment because you might have experienced that.
Yeah. I mean, typically, we have always had within the Swedish, particularly in my area with OB, we've had exceptions where we felt that the humane thing to do would be to cautiously expand who could be there. But you don't just leave it wide open. So usually the bedside nurse doesn't have the ability to say, oh yeah, that's fine. You might need to get the charge nurse or the manager involved or something like that. And it should be that the bedside nurse hears your story and responds and does that for you. But just if it's really important and you're not feeling like you're getting traction, most places will have the commitment to the not only the physical care of the patient, but the heart and soul of the patient and the family as well, to be able to make careful exceptions. So I do feel like that's where an advocate can really make a difference for a family and for a patient, is to have that voice in a respectful way and just say, this is really challenging for the family that I'm helping through this emergency or through this complicated healthcare issue.
Yeah, that's a great point. That's great. Well, thank you so much, Dale. Thanks, Beth. Thanks, Tina, and for all of you for sharing the time with us today. We will have another call next month. And also just be on the lookout for our invitation for the November 4th and 5th conference. So we hope to see you there, and have a wonderful, wonderful Monday. Bye.
Thank you all. Bye.